Good afternoon, everyone. This is Siddharth Amber from Chicago Arthritis and Regenerative Medicine. Today, we are talking about regenerative medicine. So what you'll get from this webinar. You'll learn about the best available treatments for arthritis and tendinitis that do not require surgery, what is legitimate in the field of regenerative medicine, and how to choose the best physicians and clinics for your regenerative medicine procedure. If you want to learn more at any time, please go to chicagoarthritis.com. So the big question is, what would you do if your pains were controlled? How would your life improve? What exercises would you restart? And what activities with friends and family would you start to participate again? So a bit about myself. My name is Siddharth Amber. I'm a physician here at Chicago Arthritis and Regenerative Medicine, in practice since 2008. Participating in regenerative medicine since 2008 as well, and within the Regenix network, which is the largest network of affiliated physicians involved in regenerative medicine, utilizing common practices, best practices, sharing results in that network since 2012. So the traditional care for most musculoskeletal issues, whether you're talking about tendinitis, strain, arthritis, joint pains, back and neck pain, is really mask the pain, just waiting for eventual surgery. It's a very inadequate model. There's a lot of short-term fixes like pain medications that don't really fix the problem, that come with their own side effects. There's the traditional injections that can give short-term pain relief, such as steroid injections or nerve blocks that can give a little bit longer pain relief, but have longer-term consequences when you damage the nerve, that are really not adequate. Surgery has a role in things that are more severe, but in things that are not as severe, it's really just higher risk and there's better options. Surgery, a lot of routine surgeries like knee arthroscopy, if you already have arthritis, can actually accelerate the arthritis process by creating more instability. And many routine surgeries, such as knee arthroscopy in the setting of arthritis, have been proven to not actually be better than just conservative care. And so for those of us involved in regenerative medicine, strong understanding and belief that 80% of musculoskeletal conditions can actually avoid surgery. In the same way that in the past, cardiac surgery, open heart cardiac surgery, was the only way to treat cardiac disease. And now it's very rarely used. There's plenty of other non-surgical ways to do that. So in searching for better options, we need options that are low risk, that avoid serious side effects, that should address the actual cause of the problem. The actual cause of the problem is chronic instability or inflammation and metabolic issues, and can actually improve the cause of the problem so that you get longer-term improvement. And we'll talk about that. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine is a process of utilizing your body's own cells to treat your arthritis, tendinitis, injuries, and back pain. The normal healing process, let's say take something as small as a cut on your finger. You have platelets that infiltrate the area. They first stop the bleeding. They then release growth factors, which then stimulate your local stem cells. That leads to inflammation, more cells that infiltrate the area, and eventually a layering of tissue down to help repair the injury. This works well in tissue that has good blood supply, but tissues with poor blood flow do not heal as well. That includes tendon, cartilage, ligaments, disc, labrum, and meniscus. Those tissues are hardy, but once they've been injured or chronically injured, they tend not to heal well on their own. So regenerative medicine is a process where we take those same cells, either your own blood platelets or your own stem cells, and re-inject that into the damaged tissue. So the good thing about that is, number one, this treats the source of the problem, which is instability and inflammation. It's safer than surgery. It's effective for most MSK conditions. And again, should be eventually will actually take over 80% of what traditional orthopedic surgery has been managing over the years. We'll then just reserve surgery for the things that really are most severe in nature. So how does regenerative medicine work? Again, we can optimize damaged tissue. You can improve strength and stability of supportive soft tissue structures around a joint. This all can lead to less instability, reduce chronic inflammation. We can also improve the neuromuscular health of tissue as well. Okay, so this is a fairly long slide, but what makes a regenerative medicine expert? There's really a lot of different things, and I'll touch base on this as we continue to talk about all this. But it really consists of a lot of different things. To begin with, your physician really should be an MSK expert, a musculoskeletal expert. And what that means is that they are trained and focused on treating joint tendon pathology. They shouldn't be dabbling in multiple other things. They shouldn't be treating erectile dysfunction in one room, concierge in the next room, hormones in the next room, blood pressure in the next room. They should be really focused on just regenerative medicine. They should be a non-surgical MSK expert. And what that really means is, our surgical colleagues are very well trained in surgery, but the kind of skill set you need for non-surgical management, which includes a lot of ultrasound and X-ray guidance of injections, they don't necessarily have. You really want to be an expert in that. They should use image guidance for all procedures. If your physician is giving these injections without using ultrasound or X-ray guidance, you're not getting the right treatment outcome. I'll show you some pictures of why that is. They should understand how inflammation helps you heal. That's important because if your physician is offering you steroid injections first line and you've got wear and tear issues, that's not really understanding that inflammation short term is actually helpful. That's how you heal. It's just a problem if it's long term. They should understand the different types of biologic treatments available, and they should give you a very personalized treatment plan versus a one-size-fits-all plan. In my experience, a lot of my colleagues give a one-size-fits-all plan, which really does not make sense given your issues are very particular to you. They should understand this concept of prolotherapy, which I'll talk about, which helps treat instability. They should be transparent in results and your candidacy for treatment. And they should follow your results long term. And of course, they should guide you through the process. These treatments, while they've been around for a couple of decades now, they're not new per se, but they are still new to a lot of physicians and obviously the general public. And so your physician should be able to guide you through some of the nuances here. So a couple other kind of really basic questions that we should touch on. Is this legal? Yes, absolutely. There are strict guidelines from the FDA, and as long as you follow those guidelines, we are regulatory compliant and legally doing this. I have colleagues that deviate from that, and that becomes illegal. But as long as you're doing this appropriately and safely, you are okay to do this. Another common question is, if I'm older, should I use someone else's cell? And the really simple answer is no. And the reason why is when you look at the data out there, for most orthopedic conditions, there's very good evidence that using your own living cells is effective. Using somebody else's cell has a potential for other potential side effects, such as your body rejecting them. Is there an age limit? For the most part, no. The one exceptions are hips, where age greater than 65 can worsen outcome, but for everything else, age does not seem to make a difference in terms of percentage improvement. As I mentioned, what kind of doctor does these treatments? Should be focused on musculoskeletal conditions. They should be focused on non-surgical treatment of orthopedic conditions, and they really should have all those things that I mentioned to be a proper regenerative medicine expert. Can these treatments help if you already had surgery? Simple answer is yes. If you've had arthroscopy, if you've had some other kind of repair surgery, if you've had your joint replaced where now you don't have your actual normal hardware, so to speak, but now you have metal plastic hardware, then this is not the right treatment in that case. My general rules for orthopedic surgery that I suggest to my patients are try to keep your own anatomy, avoid surgeries that are just cutting out tissue, not actually repairing things, and always consider regenerative medicine treatment option if you've been recommended surgery. See if you're actually a candidate. So we're going to touch on some key concepts of regenerative medicine. Stability and prolotherapy is a big one. There's this concept in architecture called tensegrity. That means is that if you take individual units that are weak on their own, put them in close approximation, compress them together, you get a unit that's a lot stronger. In biology, that is called biotensegrity. So prolotherapy is the idea of injecting your own cells into those individual units, soft tissue structures, to create a stronger overall structural unit. The key here is that you want to treat all the layers and depth of treatment, which I'll touch on, and you will get a slow and progressive healing over time, which then gives you longer lasting results over time. So case study for a lower back patient, 71-year-old man. He's had chronic lower back pain, prior surgery times 2 already. He had a laminectomy. They're cutting out bone, and he's still having pain, very common. So we end up treating all the layers that are involved. That includes this epidural space where the nerves come out, the muscles, the set joints, and the ligaments. Originally gave him PRP. He had initial improvement. We then had to escalate to using his own bone marrow stem cells, and he's been doing really well for the last couple of years. The keys here are, yep, we escalated to a stronger treatment line, but also that we had to treat all the different layers. By treating all those different layers, that's what's really helped him out. Next concept to understand are orthobiologics. These are the cells that are injected into your damaged tissue. Again, uses your own normal healing process. Use your own cells. Don't use somebody else's cells. So platelets are the most common orthobiologic that's used. And after an injury, as I mentioned, platelets are key to get your body to start healing. They actually do stimulate your local stem cells. They use focus inflammation, and they stimulate those stem cells. So there's different types of platelet-rich plasma. And to begin with, if you look on the right, you'll see that there's 2 different types of platelet preps here. There's one that has a lot of red in it. That's very bloody platelet-rich plasma. That'll cause more inflammation. We don't want that. And there's a picture on the left that's amber colored, where you've taken out the red blood cells. Higher concentration, no red blood cells, better for the joint. So we'll use a very high concentration of platelets for your joints, medium concentration for tendons, and we'll try to use the amber colored one. The red colored one you can use for more muscle related issues. That's fine. We'll also create a different type of platelet prep called platelet lysate, where we take the platelets, crack them open, and just take the growth factors. That's better for the nerves. The key here to understand is that this is not just a simple blood draw, centrifuge, and re-inject. This is really picking and choosing the right type of platelet prep that's right for you. Most of my colleagues that do these treatments are just using a one set type of platelets. And that's all that they use for everybody, instead of varying what to do based on what your issue is. You deserve that kind of bespoke approach. So this is an example of a 45-year-old man, cyclist, referred to me by a sports medicine physician. He has patellar tendinitis. Picture on the right is his patellar tendon. Just show you what that looks like. This is the tendon here. That's the patella, the bone. These are little bone spurs in the patellar tendon. That's what's causing his pain. Right. So he ended up getting PRP treatment 2 times. First time he had good response. The second time he needed a second treatment to really get him back to 100%, back to his normal capacity. He did great with treatment. 3 years later, we treated his other leg now with his own platelets for a hamstring injury. Again, did great after treatment, back to cycling, doing great. Picture on the right here is that same picture with the tendon. The difference now is we also now have under ultrasound guidance, that's the needle injecting into the tendon itself. So the keys here are, number 1, platelets are a great first-line option for tendon-related issues. Number 2, it's that repeat treatment can make a big difference. Platelets, we'll generally use platelets for mild to moderate issues. We'll then escalate to something like your own bone marrow stem cells if you've got a moderate to more advanced issue. Again, your stem cells are the main cell that drives tissue repair. Use your own cells, not somebody else. So important. In the United States, bone marrow-derived stem cells are legal, fat-derived stem cells are not. You can still use fat or adipose for structural support, but that's not, strictly speaking, a stem cell treatment. Great. So you may, in the past, have heard of amniotic cells, umbilical cord cells. In the United States, these are considered illegal. Probably don't hear about them as much. You may hear about IV stem cells being used in other countries. You may get some benefit from an anti-inflammation standpoint, but realistically, there's really no proven benefit for orthopedic conditions in the literature. So what are some realistic outcomes with stem cell treatments? So can we improve your issue if you've got advanced arthritis? So simple answer is we can improve your pain, we can improve your function. It cannot necessarily change what your x-ray looks like if you've got advanced arthritis. On the other hand, can we improve your x-ray images if you have a tendon tear or ligament tear? That tear is still at a reasonable size. Yes, I'll show some images of that. If you've got swelling in an arthritic joint, we can improve that. And if you've got damage in the bone, we can treat that as well if you're catching it at an early enough stage. Can we treat bone-on-bone arthritis? This term bone-on-bone is a really bad term that some doctors use. It sort of gives the impression that it's hopeless. And the thing is that arthritis is a biologic condition. It's not strictly an X-ray condition, right? And you can use biologic treatments to treat a biologic condition. So with advanced hip osteoarthritis, it's challenging. But for other areas, whether you're talking knees, back, shoulders, ankles, like these are still very likely to improve in pain and function, although we can't necessarily improve how your imaging looks. It's an example of a gentleman who came to me. He was a 28-year-old man, volleyball player. He's a recreational volleyball player. He's a butcher by trade. He had an ACL tear. I saw him shortly after he had torn his tear. Treated him shortly thereafter, and a few months after his treatment, he was doing wonderful. Really just outstanding in terms of his pain relief, in terms of his ability to get back to activity. Also had an amazing image improvement. I'll show that. Picture on the right is an X-ray image of his procedure. First pointer there, that's his patella, kneecap. That's the femur. That's the shin bone. This is the needle. And what's lighting up here is the ACL. You can really only do this kind of procedure under high-level X-ray guidance. So how did he do? So he had not only a great clinical result, he also had really quite an outstanding MRI result as well. And here's what we're seeing. So MRI on the left, again, that's pre-treatment. This is his kneecap, thigh bone, shin bone. Here's the ACL. That's the bottom, it's intact of the ACL. When you get to the middle of the ACL and the top of the ACL, very hard to make it out, very hazy. The radiologist has read this as a likely full thickness tear. 3 months after treatment, here's his MRI on the right side. And now you see an ACL that's fully intact. Still a little bit of fluid around the ACL, but that is a fully intact ACL. So he's had not only a great clinical outcome in terms of getting back to activity and no pain, he's had an absolutely wonderful MRI outcome as well. This is a 57-year-old contractor patient that I treated with his own bone marrow stem cells. Again, great clinical outcome in terms of pain relief and getting back to work and activity. He also had an absolutely wonderful image result. So the pictures on the left, these are ultrasound images of his rotator cuff. This black area right here, that is tear of the tendon. All right, that is a full thickness tear. This is 3 months after treatment, and now what you see is that area has filled in. There's new tissue growth there. This is really a great outcome, right? It's hard to predict some of these things, but this was really a wonderful outcome in someone, not only pain and function, but also imaging. The next concept to understand is interventional orthopedics. This is the idea of using high-level image guidance to treat orthopedic injuries. So important to understand this, and the reason why is because I do still have colleagues who feel that just by palpating the skin, they can determine where they want it to fight. And the thing is, that's not really accurate. So, and here's why. So here's a picture on the left. It's an ultrasound image. That's the main rotator cuff tendon, supraspinatus tendon. This is the needle injecting into the tendon. And this very small little gap here, that's the tear. That's very small. This is a zoomed in image, all right? That tear is probably about 1 millimeter by 1 millimeter in dimensions. To inject that blindly would be impossible, right? That's a needle in a haystack. But by using the tools in the office, we can do that. Picture on the right, it's an X-ray image of injecting the joint to the labrum. That's the ball, that's the socket of the shoulder joint. That's the needle. This is an X-ray image, by the way. What's lighting up in here, that is the joint. We've confirmed we're in the joint. And this triangular structure, that's the labrum. What's wonderful about this is most of these tissues, they will not respond well to treatment if you don't hit it exactly. And in these cases, we've hit it exactly. You can only do that if you're using high-level image guidance. I have colleagues who don't feel like they need that, but from my standpoint, until I have X-ray vision, I am going to continue to use the X-ray machine and the ultrasound machine in the office. These were, again, images that I showed earlier for injecting the knee. The one on the left is for patellar tendinitis, and the one on the right is for the ACL injury. It's a nice case study of an individual who had ankle AVN. He's a 41-year-old chef standing on his feet all day long. He developed avascular necrosis, which means death in the bone. So the picture on the left is an MRI image. This is the ankle joint. There's a little bit of fluid there. And this white color here, that is avascular necrosis. That is basically the bone is starting to die. We injected into his joint as well into the bone. 3 months later, you now have healthy looking bone tissue. The swelling is gone. Pain is dramatically better. He's doing great. That's a great outcome. And we caught him at the right stage to not only help him out, but to help prevent this from getting. Regenerative medicine treatments offer you safe and effective solutions for your pain. By the way, please leave any questions you may have in either chat or Q&A section, and I'll answer them as we go along. So common other questions I get, is this too good to be true, right? It's interesting because I have colleagues that, maybe 10 years ago, they would tell their patients, look, they don't think these treatments work. Where's the evidence? And the reality is that there's evidence that goes back to the mid-90s. Philip Hernigue is a French orthopedic surgeon who's been doing this treatment since that time. Regenerative Network has data since 2005. These treatments are newish, right? But they've been around for a while. This is a rapidly developing field, but it's not new. My own personal experience is since 2008. This is 2024 as of this video, this recording. So it's newish compared to other things, but definitely not new. There's definitely right and wrong ways to do this. And your expectation should be grounded in reality, evidence-based medicine, for sure. But definitely not too good to be true. These are realistic results and realistic patients and treatments that we're using. How long do results last? Regenerative has data that goes over 10 years. Philip Hernigue has data that goes over 20 years. So there's good data on long-term improvement. However, what I tell patients is if you have a chronic condition, expect that you need a repeat treatment at some point. Now, that could be that you get a bone marrow stem cell treatment for your knee on day one, and then two, three years later, you're getting a platelet booster treatment, right? The data that we have shows that booster treatments make a big difference in terms of keeping people healthy and continue to do well. A great question somebody asked, how are bone-on-bone knees treated? The key, so a couple of things. Number one, knees are amazing in terms of how well they respond to treatment. They're hardy. You can take someone who has bad arthritis of the knee, and yet they can still almost fully flex their knee. They can still bear weight. The knees they're built for the kind of life that we live. And the keys to getting somebody better are that you want to treat every level that's problematic. Number one, you want to treat the joint for sure, right? If that's where the arthritis is, right? You want to treat the ligaments around that, the soft tissue, the muscles, the tendons all around that, nerves if appropriate. And in someone who's got more advanced arthritis, even treating the bone itself, right? Because the bone, the blood supply from the bone actually feeds the joint itself. And if you treat it comprehensively, people can do really well. Someone else with a good question. I'll get to that in a second, actually. So what are the best ways to maintain results after treatments? Improve your biomechanics. That's likely that something with your biomechanics, how you're doing activity, walking, symmetry, all that is maybe contributing to your problem. Improve your biomechanics, that should help. Use the appropriate joint supplements. There's some that are really good options in terms of pain and inflammation. Repeating treatments is additive. right? So what we know is that you'll get a good response, good progressive, slow response after treatment for several months. At some point, for platelet treatment, it may be after 6 months, you'll start to plateau. For stem cell treatment, it'll be after a year. At some point, you'll start to plateau. And if you're at your goal, wonderful. This is how you maintain things. However, if you're not at your goal, let's say you're 50% better, and you're trying to get to 75% better, well, then a repeat treatment will take you from this higher level and stair step you to the next level. The next one is certainly maintain ideal body weight, especially if you've got lower back and leg issues. If you can reduce the stress and the weight on them, that makes a big difference. But also, if you can improve your metabolic health, that helps with inflammation. That's a big part of what drives pain and swelling and inflammation. So in our clinic, we happen to have a physician-assisted weight loss program where we utilize semaglutide to help with weight loss and metabolic health. I would strongly recommend that as well to maintain an ideal body weight if you're trying to treat your lower extremity or lower back arthritis, but also to maintain your results as well. Right. So this is not routinely covered by insurance. So the one exception would be Regenix Corporate. All right. And these are essentially Regenix has a corporate plan where where we actually have carved out the benefits plan for different private companies that are self-insured so that these are now part of their benefits plan. And there's roughly 500, 700 companies that are doing this now throughout the country. If your company has that as an option and you want to add this, go to regenixcorporate.com. If this is something that your company already has, great, it's covered like any other insurance benefit. If it's not covered, however, here's kind of the expected prices to see. This is kind of typical throughout the country. That would include prolotherapy, which is a milder type of regenerative medicine. That's for $750, PRP is $2,500, and then using your own bone marrow stem cells about $7,000. Keys to determine value, I'd recommend number one are your physician clinic regenerative medicine experts, right? We went through that list. Do they really know what they're doing? Are you receiving a real stem cell treatment or something that's kind of bogus, like amniotic or umbilical cord cells that's being mislabeled? And understand that these are in-office procedures. Avoid hospital and surgery center. Thus, you can avoid hospital and surgery center fees if possible. Okay, somebody asked a good question. Who cannot be treated? Such a good question. The way that I look at it is it's a matter of deciding your candidacy. So as an example, let's say someone's got bad hip arthritis and their range of motion is very bad. They're 75 years old, got diabetes. That's a challenging candidate. You'd have to tell that person your chance of getting more than 50% improvement is about a 1 out of 3 chance. Knees, on the other hand, you can take someone who's got advanced knee arthritis. They usually respond pretty well. What I would recommend, I think you have to also look at it. Well, what other meds are they taking? Are they on chronic anti-inflammatory meds? Are they taking prednisone? Do they have uncontrolled diabetes, uncontrolled thyroid issues? If they have any of these other issues, that can make them a challenging candidate. And what I'll tell them is get that systemic issue treated first before we kind of move on to treatment. I see a lot of autoimmune patients, and so I do have patients who will come to us asking if they've got rheumatoid arthritis or psoriatic arthritis. Can we treat them with stem cell? Or I normally tell them as, look, if your overall body condition is way out of control, you need to get that control first with traditional methods. And then if you have 1 or 2 joints that are still problematic, then let's talk about how we can optimize things. So, who cannot be treated? There's good, fair, and poor candidates. Every once in a while, you'll see a poor candidate do well with treatment, but normally they're challenging candidates. And so for each joint, we know what that is. So it depends on which joint you're talking about. For knees, though, usually, as long as range of motion is pretty good, as long as you're generally healthy, you'll probably do well with treatment. If you've got other medical issues, if you're physically impaired, you may not get that on average 70% improvement. You may get more like a 50% improvement. So it just depends. So we talked before about all this, what makes a regenerative medicine expert. I won't kind of go through this again, but understand that it really takes quite a bit. And I do think that if you're looking for treatment, make sure your physicians really meet all these criteria. Just a little bit more about how we do things here at Chicago Arthritis. Right. So we are focused on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain. Starting off with evaluating, do you have inflammation, instability, asymmetry, and neuromuscular issues? trying to correct with low-risk interventions if possible. If you already failed that, then we talk about what else can be helpful. If you meet criteria and candidacy, then we talk about regenerative medicine treatments using the highest quality products in your own body, a plain plan that is specifically tailored to your own condition needs, and delivering cells using the highest level of image guidance to give you the best chance at a good outcome. Great. So if interested in getting evaluated, if you look in the webinar chat section, you'll see that you can contact us in multiple different ways. You can go to our website, chicagoarthritis.com. You can call us for an appointment. You can email us for an appointment. And you can even directly schedule an appointment with us through our online scheduling appointment scheduler as well. So these are all ways that we are here to help out. So we are progressively getting toward the end of our talk today. If there's any other questions, please let me know. I hope that was helpful. And understand that if you do have a chronic musculoskeletal issue, there are lots of ways to help improve things without having to go the full-on surgery route. And if it's a regenerative medicine treatment that makes sense and that's appropriate for you, we're here to help out. You're welcome. Appreciate your time. Thank you for the thank you. And if there's any other questions after this video, please contact us at your convenience. You will get an invitation to rewatch the video in the next probably day or so. You can either watch it yourself or have a friend, colleague, or family member watch it if interested also. Wonderful. Well, thank you everyone for your time. And until we connect in the future, I hope everyone stays safe and live well. Bye-bye.